Thank you. Is it necessary to replace fluid suctioned out of an NG tube when treating a small bowel obstruction?
My personal opinion, no. I have, in my training and even afterwards, I didn't think that it ever did something. However, I could be wrong about that. I usually do not make it.
Do you need to replace IV fluids when you have NG suctioning with a small bowel obstruction?
You mean add extra IV fluids to replace what's been sucked out of the gut?
Yes.
Yeah.
Yes.
You know, I agree with Dr. Branch. I think, you know, it's there. It's not, it's gone. It wasn't in the
intravascular
space in the
compartment
first place.
anyway, yeah.
Now that you sucked it out, it's still not there. And you don't need, I mean, if you made your calculation for fluid replacement, you don't have to add an extra, you know, 1,500 or whatever the hell you drew out of the stomach to get that person back in a better vascular state. So now if they've been there for, you know, if it's the third day, of course, Dr. Branch will let them stay that way. He'll cut on them first.
That's right.
But you know, when you're talking 2 and 3 days, actually you're reassessing their fluid status anyway. You know, all of these are all, Dr. Roche will tell you, these are all best guesses because everybody's different. And this, you know, like your 80-year-old versus 80-year-old vomiting and diarrhea person versus the 20-year-old diabetic. Once the diabetic sugars are controlled, you know, and if you've done reasonably good fluid replacement, they're a lot more stable, and the other person isn't. And they may have some renal failure. There's just a lot of other things too. You have to keep all your wits about you and take care of the patient.
Okay, I agree with your assessment of that too. I think even just in under the thought of making things more simple for nursing and things like that, it just. But yeah, it wasn't in the intravascular space to begin with. So.
All right, next question is, why do we use different fluids for pediatric patients and neonates?
Guess it's me. Well, so in the newborns especially, we tend to go with, now if you're given a bolus and they seem like they're hypovolemic and they're poor perfusing right at delivery, then you may use like normal saline or like an LR type of thing, just like a normal bolus. But the neonatal resuscitation program, the NRP, suggests giving like the D10. And often if we call the neonatologist, they'll say, yeah, you know, run as a maintenance fluid D10W. And of course, this is because the newborns are so tiny, they can't go like an adult for, you know, a day or two without eating anything. Their glucose will be, you know, long gone. And so they have very little reserve in that sense. And so we would want to give, you know, fluid with glucose in there. And pediatrics, I think it's getting more and more to be like, more like adults, and it's moving, the whole IV fluid stuff is sort of moving more in the, you know, normal saline with some potassium and LR with some potassium, whatever, instead of doing this quarter normal, half normal, all these different things, and keeping them without D5 unless they really need it for some reason. So I think that's probably going more closer together as adults.
Well, I have to add something about the D5. I like to use D5 lactated Ringers, for example, or D5 half normal saline with potassium. And the reason is, especially in a surgical patient, you're looking at 3, 4, 5, sometimes a week without eating. And we know the brain lives on glucose, and the body's going to make sure the brain is fed. And if you don't have the D5, which does not produce that many calories in the first place, it's just enough to keep from muscle breakdown, that is, protein breakdown to get the alanine and convert that to glucose to feed the brain. It's just enough to keep that from occurring, so I continue to use that.
I think that's great. You know, your patients are certainly different than medicine patients. So I think that's always going to be needed.
All right.
Come around the other way.
It sure will.
Hopefully we're making ours, you know, better in the first day or so, and they can eat. You know, that's
Yeah,
totally
that's a
different
different thing.
than our post-op patients.
When are 2 IV sites needed?
Oh, that's easy for me.
Okay.
In surgery, it's an easy solution, an easy answer. Some of my drugs are not compatible, and certainly not with blood. If I'm gonna be giving blood, or even if I think I'm gonna be giving blood, I will start a second site because propofol and some of the other drugs I use are not compatible. Plus, if a patient is unstable enough to be requiring blood, or even if I think they'll be requiring blood, having a second site gives me a second option, because one never knows if a IV will fail, and this way I have a site ahead of time, even if it's just a saline lock. Also, the first IV may have been a small IV. It may have been not anticipated that a surgery would be more extensive. It may have been, oh, it'll be a small cyst or something, and then it turns out to be a much more involved surgery than was anticipated. So a larger IV would be called for. So that would be another reason. Another reason is sometimes the patient has very small veins, and so a very an important storm sort of IV was started, and after they're asleep, we'll get a vasodilation, and I'll find a larger IV. And this patient will be is destined to be an inpatient, so I'll start an IV for nursing access, just because they'll have something that will be more comfortable and more convenient for and then I won't stop the first IV, because I'm not gonna pull a good IV because I've got another IV, and I'll let them decide that later. So those are my main reasons for starting a second IV.
In the medicine world and in the ER and things like that, when if they're in shock or they're in sepsis, a lot of times you need to give a lot of fluid and a lot of medicines all at the same time, so it's often good to have two sites, and then you can give
Right.
antibiotics in one and fluid in the other. And
Yeah, even if it's not blood, I do have another fluid site too, and very frequently resuscitation is two crystalloid sites too. Yeah, she's right. If I'm not giving blood, I can often give crystalloids too.
Okay. How do we determine the fluid rate?
So I talked a little bit about like
Yeah,
the
you
4-3-1
talked.
thing and how there's a lot of controversy surrounding. I don't know what you guys
Yeah.
think of when you think about what rate to give.
Mine is, I was taught by head of pediatrics at Kearney Hospital, which is Dorchester, just south of Boston. And he was actually a controversial guy, but it was the up to 10 kilogram weight, 100 milliliters per kilogram per day. After that, then from 10 to 20, it was 50 milliliters per kilogram per day, and then after that, it was for anything above that was then 20 milliliters per kilogram per day. And I still do it the old-fashioned way. That's the way I learned.
Actually, if you calculate it out, it's pretty much what that fortune was.
Yeah,
It's-
because those are per
it's really-
hour. That's
It's really, you're calculating in a slightly different way, but coming up with the same answer.
And for me, it's a totally different ballgame, because I'm working on
Yeah.
a different time frame with different kinds of patients. And
yeah.
it really depends on what's going on. And there is really, when I started, there were set almost formulas, and now there's so much controversy. There's the dry camp and the wet camp, and right now, try as you might, you won't find a set of rules as to, and formulas as to what to give. It really comes down to the patient, what's going on, and the type of surgery that's going on. So until maybe we find out more, it's somewhat individual. Even though measurements are not, no one even has decided how to measure that.
All right, thank you. We're running out of time. Does anyone have any questions for the panelists before we finish?
I had one question. So is it better to give like 4 riders or put the 40 a K in a liter?
That depends on fluid. I mean, do we have a fluid problem? You know, is extra fluid gonna be a problem with the liter rather than the 400 milliliters? That's really the question.
Or can they eat and drink, and can you get them to take it in the room?
Yeah.
I agree with Dr. Sandy with that. If they can eat and drink, I prefer to give it, I prefer if they would take the elixir, that works
Yeah, you're not
the
gonna
best.
get
That's the
somebody in
most-
trouble
yeah,
orally. I mean, that's
most
what I've always
effective,
been
most
told.
efficient. Supposedly it tastes horrible, but
Yeah, but
Yeah.
it'll
It
go
does
to the
taste
gut.
horrible.
It's very bad, and you have to glue it in a fair amount of fluid. You have to give it 6 to 12 ounces, depending on how much you give them,
cups.
because, it must be.
Yeah, but people expect it to taste
But
awful
it is,
in the hospital.
that's true, that's true, all the stuff they're taking probably tastes terrible, but it's certainly, I think it's less risky as well.
It is.
And I think it works faster too, it's much more efficient.
Good old gut.
That's right.
I truly believe that.
But yeah, if they can handle the fluid, Lori, I'd like to put it in the fluid. You don't always have that option, but.
All right, thank you,
Thank you.
panelists.
Yeah.